Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article number 36. Welcome to the Pain is Not the Only Problem podcast. Article 36. Pain is not the only problem. Subthreshold Microtrauma Part 2. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction, and clinically meaningful results, recommend a conservative non-surgical course of care to override pain instantly, and restore ADLs and patient confidence on the first visit at low cost. As previously discussed, subthreshold microtrauma, STMT, as described by Dean 2016, describes subclinical soft tissue injuries or damage. Soft tissues are voltage-gated tissues, such as fat, muscle, fascia, believe it or not, lymph, believe it or not, arteries, veins, and nerves. And then hard tissue injuries or damage. And these are described as collagen-based tissues, bone, ligament, tendons, cartilage, implying that the patient is asymptomatic, that's key, and not seeking care. That is the subclinical, subthreshold that we're talking about, and is likely due to an abnormal movement pattern, a faulty movement pattern, and associated with the symptomatic area of tissue, but not always at the symptomatic area. The key components when we're describing subthreshold microtrauma are that they involve the voltage-gated tissue and the non-voltage-gated tissues. Voltage-gated being soft tissue and not voltage-gated being known as hard tissues. And the patient is asymptomatic and has not looked for care. There's nothing causing them to go to the doctor or to even examine themselves. This is likely due to an abnormal movement pattern and is associated with, but not always at, the symptomatic area. So there could be, at some point, symptoms, but that does not mean that the faulty motor pattern is associated with this symptomatic area. The two can exist separately or they can exist together. In which phase of healing do people seek medical intervention? Well, usually when they have symptoms, but not always painful symptoms. They seek intervention when either of these 5 cases occurs. 1, the pain is unbearable, or the pain exists at all, but usually when it's unbearable. 2, the pain interferes with daily activities, work or sports performance. 3, movement is made impossible due to pain. 4, there is fear that the problem may get uncontrollably worse, might be untreatable, and not get diagnosed. Or 5, their preferred treatment plan is not covered by insurance, and when out-of-pocket costs possibly would be high. All of these circumstances describe the threshold at which the patient or the athlete can't suffer anymore. They're seeking care. It is the responsibility of the clinician to explain subthreshold microtrauma and how it will be treated. So remember, there's the subthreshold before they come to the office, before they know that there's something wrong. And then there's the clinical experience when they actually seek care. And there's a transition in between the two. The subclinical zone represents tolerable limits of ADLs and sports performance, even in the presence of unresolved tissue damage. The intolerable zone is when the patient comes to the doctor or comes to the clinic or starts to seek outside care, and represents intolerable limits of symptoms and functional deficits. Well, each patient or athlete has a different level of tolerance, but the area between the two is variable. One patient may have a higher tolerance or might put up with the fact that they can't, for example, do their forehand if they play tennis, right? So their forehand is getting painful. Well, that's different for everyone. So we can't say automatically that a let's say 5 out of 10 is when the patient is going to seek care. It could be when it's a 2 out of 10, or one patient's 5 out of 10 might be a 1 out of 10. So you have to understand that there's this subclinical zone, and then there's the clinical zone, and the threshold between the two is variable per patient. Let me remind you that there are two variables. There is the functional or performance variable, and there's the symptom variable, and they don't always correlate. They don't always move together. Certain people may become very dysfunctional in an activity or in a movement or an occupational drill or skill that they have to have. And they may persist with that dysfunction, even though it doesn't cause pain, right? And this is an example of people who pronate their feet. They walk all day with their feet pronated. It doesn't particularly hurt, but that's a tissue damage. So this area above the threshold is where the patient has met with the doctor or met with the clinician, and they discuss the extent of the tissue damage. Many times they also talk about the pain. Obviously, there's been some tissue damage, and the patient is seeking care. Over time, let's say in that zone below looking for the clinical assistance, the tissue damage isn't linear. Let's pick a knee problem and say there's a problem with stability in the knee, and the patient or the athlete has no idea that they're turning their knee slightly inward while they extend their leg, or while they run, for example, or play soccer, or go up and down the stairs, or maybe even getting in and out of the car. They're not aware of it. Well, that will happen a couple of times, then the body will try to heal that because it's tissue damage, but it isn't enough tissue damage to ask the patient or the athlete to do something about it. Now we have a slight repair, but the patient goes on their merry way with their lifestyle, and the tissue gets injured again. But this time, because there's a previous injury that was healed, the new tissue damage is sort of additive. So the new tissue damage is more tissue damage. Obviously, the body tries to heal that. But now, since this has happened twice, the body can't heal it quite as well, right? So it's starting to modify how the joint gets used slightly. So this sort of back and forth is all still happening subclinically. And I'm not talking about someone who falls on their knee and it repairs. Then they fall, darn it, they fell on the knee again and repaired again. We're not talking about traumatic injuries. We're not talking about incidental injuries, right? We're talking about these ongoing subclinical, subthreshold, no evidence of tissue damage. And we're going to call these microtraumas. And we're not talking about, a cell or two. We're talking about a set of tissues, let's say a ligament or a tendon, possibly, and then maybe there's a bit of muscle, and maybe there's a little bit of nerve problems that happen from this, and maybe there's a little bit of inflammation, and that's irritating the nerve. So this is all happening in the background without calling any attention to the patient or to the athlete. So this is that subclinical, hasn't been to the doctor, subthreshold, which means it hasn't caught the attention of the patient, microtrauma, no patient complaints. Right, so this goes on and on and on. These injuries and resolutions, new injury, resolution, new injury, new resolution. This is going on over time, and we can't say it's a day, a week, a month. It could be years. It could be a decade. It could be, 5 years of being hunched over in a chair at a job. The microtraumas are contributing to that upper cross syndrome. So I don't want you to think about something incidental. There's no trauma here. So what happens in this zone before they go to the doctor is that people are going about their normal life. And in this zone before they go to the doctor, what I'm saying here is they may slightly be changing how they move. So we talked about that in the phases of healing. We talked about how the patient is sometimes going to be modifying how they move around an injury. So if we take this knee, for example, maybe the patient starts to lean on the other leg a little bit more, as a unconscious sort of antalgia. Or maybe they spend less time on their knee, or maybe they don't realize it, but they're like, I don't want to go to the gym because, something's wrong. I don't know what it is. And they don't want to make it worse. So now there's sort of a detraining effect. So they, don't know what's going on, but they're starting to get a sense to modify things, but they don't have a diagnosis and they haven't been to the doctor. The threshold of tolerance is reached. Okay, so this is like, the patient seeks out care and is likely prescribed palliative care and drugs to reduce the pain and symptoms. So the doctor may order an X-ray or an MRI, or there might be a surgical consult recommendation. And so this is where they start to try to figure out what's wrong. And the patient doesn't remember, I didn't do anything specific. It's just, I just go to work and I come home and I just feel like something's off. And I don't know, maybe it's my leg, it's my knee, but it hasn't been addressed. So the tissue damage, the faulty movement pattern, the phases of healing are not discussed or haven't been discussed. The doctor doesn't talk about faulty movement patterns, and certainly the doctor is not going to talk about those 5 phases of healing. So they're going to talk about palliative care, helping them feel better. Okay, so this results in endless palliative care, and this delays healing, and it adds cost and frustration to the patient and for the clinician. So the clinician doesn't have any idea what's going on. They don't know the diagnosis. And because of the way the common medical model goes, they're not thinking about these subthreshold microtraumas. They're thinking about things a little more obvious, like a sprain or a strain, or a broken bone, or an event that can be explained. Let's say a motor vehicle accident, or they tripped and they fell, or it's a sports contact like blunt trauma. So what happens is the patient gets sort of stuck in this undiagnosed zone where there's no tissue repair happening because there's been so much microtrauma sort of built on top of each other. Now there are these symptoms, and the symptoms get addressed, but the problem doesn't get addressed. This makes the patient get irritated because they want to play, or they want to be able to go back to work, or they just want to be, sort of symptom free. So that's where all the target is. And we've talked extensively about not diagnosing only pain, because pain is not the only problem. What do you do when, you're stuck in the zone with your patient and you're like, oh my gosh, what's going on? Remember way back on article or podcast number 4, we did zoomed out. So let's think about zooming out, because if your patient is stuck in this tissue repair abyss, right, where tissue repair is absent, ADLs and sports performance is impossible. There's no functional diagnosis that's absent. Tissue repair treatment plan is absent. And so the focus on pain becomes the wrong treatment because it's only palliative. And so there are increased patient costs, which we don't want, and we have lost time, which we don't want. We don't want to delay the healing. And then there's an opportunity here for surgical failure if the patient is directed down that route towards the invasive treatment plan. So what we don't want to do is for the patient to spend any more time than they have to being undiagnosed and being functional again. So we want to get them functional by encouraging the tissue repair process that we talked about in the acute or post-acute or chronic or post-chronic. Any of those phases can have an opportunity for resolution and discharge. So what we're looking for is to diagnose the faulty motor pattern today. And we're going to start directing the tissue repair process today. So I'm talking, when I say today, I mean on the first encounter. And then we're going to have restoration of function that happens today. And then RTP, return to play, and return to work, RTW, seems possible. Now, it's not going to happen on the first day, but it does seem possible. And then we have, of course, our big happy smile is on the patient's face because they're satisfied today. So this is all the process of zooming out, right? Stop treating pain only. And so I'm going to say stop treating pain only today. We're at this point now, we're going to look back at our sort of mission statement. Remember, these articles intend to reevaluate the prevailing clinical practices thought to manage low back pain. So that's our part 1 goal. And we've done that. We've evaluated many of the clinical lenses that people thought were okay, or they thought that they were doing the right thing, attempting to manage low back pain. And then I put pain in parentheses because it should never have been the focus in the first place. The first intention of the articles was to reevaluate the prevailing clinical practices thought to manage low back pain. If we reevaluate that, then we have this other lens where we do things like we zoom out and we consider the inflammatory or the chemical or the immune component that contributes to the patient's problem. And we talked about defining pain at all. And in the definition of pain, we had to accept that there could be pain with absolutely no generator that can be explained by science. And so that's bothersome. And then we talked about afferent signaling, disafferentation, spinal stability. We talked about sagittality. We talked about the troubles with using advanced imaging and even just plain film, right? We talked about updating the diagnosis and the treatment plans, trouble with epidurals, and including the phases of healing. So all of these clinical ways are not considered in the usual course of care. So we looked at the usual course of care and we said, well, we need to reevaluate this prevailing clinical practices. We're going to kind of zoom out and we're going to zoom back in. And so that's what we've done with 36 of these presentations. And then the second part of the intention is to submit and debate novel low back pain contributors and mechanisms. I spent about 1,200 hours of my time to do the research and collect the research and sort of crunch the information to bring it to you and then to create the presentation itself. So all of that time is what you're hearing the result of that now. So, I wanted to say, hey, look what I found, and let me share it. And then, I want to get some feedback about what everyone thinks about this. We did look at the contributors and we looked at the mechanisms, right? So what I mean by contributor, commonly we would say disc herniation, and that's okay. I'm not going to say no, I'm going to say maybe. But my point here is that we're going to submit and debate novel or new low back pain contributors. We're not going to talk about the old ones. We're going to talk about the new ones. But even if we're just talking about disc herniation, we accept that. It's not novel, but it's within the usual prevailing clinical practices. So I'm going to propose here, okay, that's fine, but you have to be able to explain the mechanism of the disc herniation. You have to be able to explain why it exists and how the body generates that and the organic reasoning for the body to create that herniation. It's not traumatic. This happens slowly over time. It doesn't appear in one day. It's a very, very, very slow process. We have to be able to understand that mechanism. Okay, so you take your pencil eraser and you've got your patient. You say, hey, look at this. This is really bad. This is, the devil. This is the damning evidence. It's right here. This is the evil that we're looking for, is this disc herniation. Okay, so we're going to say that that's a contributor just for the case of the argument. But then I'm going to say, but then you have to explain why it's there, how and why it got created. The body doesn't do anything at all without good reason. It isn't even going to grow muscle without a really good reason, and it has to be pushed extensively to grow muscle. You don't grow muscle from doing 10 push-ups. So the disc herniation is the body's proactive way of resolving some kind of situation, right? Just like the function or the mechanism of lymph is to clear the areas between the cells. It has a function. There's a whole process of it circulating around the body and doing its job. And the same is true with digestion and renal function. You can pick anything. They all respond to the chemistry, to electricity in the body, dynamic changes in action and function and chemistry and use. Right? If you drink soda instead of water, there's going to be a reaction in the body, and the body is going to call on its mechanisms to help keep the body stabilized and functioning. So even if this disc herniation is there, and we say, okay, it's there, and we're just going to say, for the sake of the argument right now, that it's, troublesome, then you have to be able to explain why the body creates it. It doesn't happen for no reason. It doesn't happen for unexplained reasons. Okay, and you have to be able to explain that to yourself, to your colleagues, and then to the patient. And it can't be a made-up story. It has to be something that can be based in science. Now, it's not included in this series, and if you've listened all along to everything, and you're meeting me here now on number 36, or you just, popped on board, and you just happened to pick 36, I have good news for you. I do have a mechanism to explain it, and it's never been told before, ever. And when I get to the point, I'll do a podcast. I might have to do a series, maybe 2 or 3 of them. I'm going to blow your mind, and I'm going to say sort of proactively, it may eliminate 90% of spinal surgeries because the mechanism can be explained. Yeah, so hold on to your hat on that one, and just, we'll announce it. Don't worry. I can explain it. And it's not because of poor posture. So you can throw that out. And I'm not going to blame degeneration. And I got a whole story on degeneration that I'll do in a separate series. That's universal degeneration. Anyway, and that one is, that information will also be of high value. Okay, so then also these articles intend to meet patient expectations and satisfaction and clinically meaningful results. So what I'm intending to say here is we can talk all day long about which surgery is better, which treatment is better, which course of care is better, but none of that matters unless the patient wants it and they need it and they care about it and it brings them results that they care about. So clinically meaningful results doesn't mean it makes the doctor happy and the doctor can discharge the patient. It means this is about the patient meeting their expectations and their satisfaction. So it doesn't matter how great your treatment plan is. If the patient doesn't want, for example, classically in the chiropractic office, you're going to be going to the chiropractor for 25 years. And, you're going to go 1 or 2 or 3 times a week for 25 years. I don't know that meets most people's or most patients' expectations for waste of time and waste of money when that kind of care has absolutely no basis in science, or I would say in medicine. You wouldn't have the same surgery 3 times a week for 25 years. So I'm going to say, and that's not a ridiculous statement because a treatment is a treatment. There's no reason to do the same treatment. It should work on the same day. So I'm going to say, if you're going to do a chiropractic adjustment, your adjustment is equal to the surgery. You do it once and then it should be done. And if it didn't do anything and the problem comes back, you need to abandon that treatment plan. And if you don't have anything else in your toolbox, then I suggest that you do have more in your toolbox. Maybe it isn't something you do with your hands. Maybe it's your understanding of scope of practice that you have. It has to be looked at and reevaluated, just like we're doing with these articles. We're reevaluating the prevailing clinical practices thought to manage low back pain. So we're taking a second look. So maybe spend your own 1,200 hours looking at what's out there and trying to compile it all together and bring your amazing message to the platform, to your colleagues and such. And then they also tend to recommend a conservative, non-surgical course of care to override pain instantly. So I'm talking about, and what I do in my office is that happens on the first day in one visit, and I don't adjust them, and I don't even need to touch the patient actually. And it isn't a list of 1,000 exercises that they need to do, but it is pretty fascinating and it works really great. That explanation is coming. So what we're looking at is abandoning the surgical option altogether. And remember, we're talking about non-traumatic, the commonest presentation of back pain. The reason why 90% of patients seek out medical care for back pain, and it's this kind of pain. So what I'm attempting to do is resolve the prevailing population of low back pain with one visit. And why one? Why not have them come back for 25 years? I make so much more money because it's the right thing to do. Because first, do no harm, never do harm. Harm includes economic harm to the patient. And then restore ADLs and patient confidence on the first visit at low cost. So why do we care about patient confidence? Because you want to build the relationship with the patient in a way that they know when they seek out care from you, you're that person that has the answers and you're going to take care of it quickly on the spot and it's not going to drag out. And so I'm just going to say, my business model here is on the first visit at low cost. So I'm working on a model where we're talking about $90 for first encounter and $35 for follow-up. And this is not chiropractic adjustment. This is the entire patient type care. Okay, and then here's the proof. Pain is not the only problem. The problem is the limitation of clinical vision to understand and treat patients, not pain. Physicians are the problem. Doctors are the problem. Clinicians are the problem. Their methods are the problem. These articles, like I said, represent 1,200 hours of my personal time to research and document a solution for low back pain while attempting to raise the accountability of all medicine to meet patient expectations and values at low cost on the same day. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-cultural willingness to strengthen medicine. Thank you.